slide, please. So this is the situation in India that almost within no time. Next, can you show the next slide and then you can come. So see the first case in India, first time in January 30th, we saw that there is one case and the students came from Wuhan. She was a medical student and came to Kerala. And then February 3 cases again. This they came from Wuhan and they all was recovered well, and we were feeling very good that we are doing well and we will not be having such problem. And then suddenly surge came in March 5th. Now can you come to the first slide, please? Next, previous slide. So can you see this, that the whole India now, March 5th surge came, and within no time, and today is April 2nd, within a month, although I will not say that it has crossed even 1,000, but almost in every state there is one or two patients, and the badly hit is Maharashtra and Kerala. But nonetheless, Rajasthan, Delhi, all the states are now almost, we are finding many pockets, many clusters, and the number of people, those who are infected with COVID, are increasing. Next slide, Vanilla. Next further. So you can see that almost a trajectory of increased number of. On March 3rd, we saw the sudden surge has started, and within this curve is only till 26th March, and if we would have shown today's curve, it would have gone further high. And we can also see that recovery is very number of patients recover are less, and although still we are in a very as far as death is concerned, and if we compare death with the other countries, I think we are quite well, that still today's number is only 40. So although people are not dying, but definitely we can see that the number of patients are increasing suddenly. Next, Vanilla. So what are the challenges which we encountered? Please, next. So we can see that the biggest challenge is testing of COVID statistics, which I feel that till March 30th, per million population, we have done only 28 tests. And that is why we can say that test positives are till March 30th per 1017 one. We don't know that how many patients are there in the community, and but because I feel, and I think whole group must be feeling that because we are testing less, that's why we are, the number of patients are less, and there must be many patients, and we can see the statistics of comorbidity, and I think it is matching to the world almost everywhere, the same thing, that comorbid people, they are dying. I see in the hospital every day a patient comes with diabetes. Today is fine, tomorrow he is in fever, he will become dehydrated, he becomes dehydrated, we take him to ICU, and he immediately, without any, it's like we used to treat so many diabetic patients, but nowadays he goes to the diabetic ketoacidosis within no time, and he last day before yesterday we lost first patient in him. So this is the way rapidly, because of these comorbidities, mainly I can say that with my experience in AIDS, that diabetes is the biggest comorbidity, because they don't unable to fight with the infection, which viral load and the lung infection, ARDS mainly, and they immediately. So a lot of patients are suffering because of these comorbidity all over the country, and the death is mainly in the 70 to 80 years of the same in India. Next slide, please. If we find the healthcare infrastructure, we can see that total number of beds, we have a population of almost 1.38 billion, but total number of beds in rural area, these are the number of beds all over the country, with all hospitals together, we have total number of beds are like this much only, and these are not only in, these are only in thousands or in lakhs, but our population is 1.38 billion. When we see the ventilators, or when we see the beds I have to already told, but ventilators statistics, we have ventilators less than 50,000 all over the country. So this is the statistics. So we have to find out some solution if suddenly we land up into the stage where other countries like Italy, America, Germany, they are passing through. Next slide. So other major challenge is very high population density. In one room, almost 10 people stay. and on an average, more than 460 people are living in 1 square kilometer in most of the states. Healthcare professionals, if we see the statistics of healthcare professionals correctly, 6 doctors are available for 10,000 population. If we compare that Italy, which is badly hit country, 36 doctors were available per 10,000 population. Lack of personal protective equipment. This is a big problem in our hospital. Every day I spend 10 minutes only on explaining to the healthcare workers that we should use PPE judiciously, but you have to take care of yourselves very. So if a doctor is inside, if it is very necessary, then only I send the other doctor or a senior doctor. Otherwise, I don't send. So lack of PPE, if it is there in aims, it must. I can understand that what must be happening all over the country. Lack of equipped ICU setup. Although our ICU setup is well equipped, but I go to the ministry meeting also, and I see that they are buying 30,000 ventilators, they are buying 3,000 ventilators, they are sending to the district hospital. But I always ask them that if you send the ventilators to the district hospital, who will run the ventilators? Because even in my hospital, we have made a pool of doctors from all the wards, all the departments. So we have a pool of almost 20,000 doctors, those who will be working for us. But when I took their training session, I realized that many of the doctors, 50% of the doctors, they don't know how to use these ventilators. So this is a big problem, even if we will arrange the ventilators. Vanilla, you can tell me the timings, and next slide, please. I am overshooting the timing. So the lack of diagnostic kit, I have already high risk population. Undiagnosed comorbidity is a big problem. And it's very funny that patients are coming, like yesterday the patients from this Momdan community came, the 100 patients together they came. They themselves were not knowing that they are diabetic. They themselves were not knowing that they are hypertensive. So undiagnosed comorbidity is a big challenge. Personal hygiene, I know that lack of personal, hardly 60 or 70% of our people, they don't wash hands before food. So I think I can say that personal hygiene is also again a problem. Social distancing, we have never learned social distancing. We always are always people, those who want to live together and want to stay together. Although we don't hug and we don't kiss, but we are people, those who really wants to stay together. So social distancing is a big problem for our country. Others, next Vanilla, other, I will show you in the food. This is the biggest problem. Although our Prime Minister, I will tell you the opportunities in 2 slides. What are the best things which we are doing? He did very well. He took a very major steps, and it was very difficult. It must have been difficult for him to take the step, but he has locked down completely this country. But what will we do with these kind of people? This must be Tablighi, Jamaat. Everybody must be knowing that when there was a lockdown, these people were doing some kind of a religious preach. They were doing some religious prayer together, and this daily religious meet has turned into nightmare for us. I can feel it. That my residents used to feel so good that this posting is so good. Hardly there are any patients, and everybody is so well settled. And suddenly, hundreds of patients came, and our AIMS department is full. All the hospital bed which we have kept for COVID patients, they are full because of these people. So, and uh, understanding these people, they don't know about their. And today, just now, I got a message that we have kept in an isolation room because there are many suspected cases, and we have sent for their throat and nasal swab. The resident told me that, madam, they don't listen to us, and they are going to each other's rooms repeatedly. So negative patient will become positive. So they are not understanding the meaning of social isolation, and they have become a total nightmare for us. Next slide, please, Vanilla. And this, although Mr. Modi has kept lockdown, but we never knew that migrant laborers, we have not planned it properly. And see, this is the main bus stop of our country, where almost when they came to know that the buses are leaving from this bus stop, they almost came together. And the prediction of health ministry is that every third person will be infected out of these people, those who have left these cities. So can you believe it that the crores of people were there together, and every third people, if they will become infected, what will happen? Next slide, Vanilla. So studies, there are multiple strategies which we have adopted. Next please. uh, Total lockdown is the biggest, I think. If anything can save our country, will be only this total lockdown. So hopefully, and the police, the way police is working, I think we should appreciate Indian police, the way they are working. They are going home, helping them. They were, if patient, the person is on the roads, they are asking him to go back. So they are very strict, and it has, if I have any, because I am a very hopeful person and I always remain very, very, uh, uh, I, my positive vibe says that we will conquer this fight. Only will be able to conquer when this lockdown is will be successful, and they are doing their best to that it should be a successful venture. Next please. So other steps which we have taken is preemptive approach. uh, on 21st March, the lockdown has happened, and all international and domestic, even the domestic flight, even if I want to go to Jaipur, I cannot go because there are complete lockdown everywhere, on roads, on railways, everywhere there is a lockdown. So people cannot go from one city to another city. I think this is the best thing which they have done. Proactive approach, strengthening surveillance, COVID task force made in each and every hospital. I don't know how much they are trained, how much they are working, but Government of India has made COVID task force in each hospital. Building capacity of healthcare system, optimizing resources, and development and approval of indigenous medical. This is a very important thing which I want to share with you, that so many companies, so many like DRDO, uh, CSIR, everybody is coming to help us. The ICMR is making testing kits, DRDO is making PPE. So all the government agency as well as private agencies like Mahindra is making ventilators, and Prime Minister Relief Fund. There are so many people, those who are donating funds, and I think we are quite wealthy otherwise. Only thing, now we have to use these resources in a judicious manner, so that we will not reach to the what we have reached. If we will reach to a stage where America and Italy is, we will not be able to sustain, I'm telling you. So again, this is very important that our lockdown is very should be successful, and wherever we are, and whosoever is listening this, wherever we are, we should try to convince the healthcare workers that how to use these equipments and where to use and where not to use. I think this ECOS platform is going to be a successful platform. It will teach people or healthcare workers that how to use these indigenous, this higher end equipments judiciously in ICUs and high dependency areas. Next slide, please. So there is a ray of hope also. The people are understanding social distancing. I can see when I go for to buy milk or any grocery, I see that people are standing 1 meter away. I feel so good that this is happening in our country. They have made all the shopkeepers have made this circle that you cannot come beyond before out of this circle and out in 1 meter. So this is again, people are understanding the importance of this, and I think I am really hopeful. Next, please. So this is my last slide, that with all these efforts, with the great efforts of our Prime Minister, with the great efforts of this eco platform, I think we will be able to teach healthcare workers how best we can utilize our training, concepts of palliative care or concepts of holistic care in this group of patients also, in this group of patients also, and we will not reach to the stage where other countries, developed countries, have reached. Otherwise, I'm telling you, this is true, that we will not be able to sustain because we don't have adequate infrastructure to handle this crisis. Thank you very much, and thank you, Gayatri, for giving me this opportunity.
Thank you, Dr. Sushma. Uh, Vinila, can you stop sharing the slide? And if you can project Dr. Sushma's CV. I'm extremely sorry. I went with the thing that Dr. Sushma is known to everybody, and I did not introduce you, ma'am.
No, it's okay. No.
So okay. Dr. Sushma Bhatnagar is the head of the Department of Onco Anesthesia and Pain and Palliative Medicine, AIMS, Delhi. and Madam is current president of IAPC, and she's also the chief editor of Indian Journal of Palliative Care. And thank you, ma'am, for preparing a wonderful overview in such a short time. And thank you so much.
Thank you very much. Thanks.
So I think we will open it for comments, questions from the participants. Any thoughts, any questions you have, you can raise the hand or unmute yourself or leave it in the chat, the question in the chat. Anyone with, yes, please
Good,
go ahead,
yeah.
Stuart.
Good. Yeah, thank you very much, Dr. Sushma. My question is, thinking about this real population that's going to be not doing well with COVID, the people you mentioned, at a rough estimation, where would these people be dying? Are they going to be dying in district hospitals, primary care hospitals, in the major hospitals predominantly? You gave the figures of number of beds in district hospitals and primary. So where are they largely going to be dying, the people who do die from this?
So I think Stuart's question is, Dr. Sushma ma'am, you have projected a slide showing beds from PHC to the district hospitals and the specialty centers. So if COVID patients are tested and they're dying, where is the death going to happen? Is that right, Stuart?
That's correct. Yeah, that's the question. Yeah.
Sushma ma'am, you're muted. You're muted.
So there will be no time to bring them over here or there, and it should not be done. I think if migrant labor has gone to village and district, I think they will die in the hospital or they will die at home. There are many clusters. Yesterday, one police officer has found out three houses where in one house 8 people were staying and suddenly one person died. So all 7 were infected. He brought all the 7 people from at home because they were hiding. So there must be many people and they will die wherever they are. I don't think that anything will happen. So district or village, they will die anywhere. Gayatri has asked me to share my experience of working with people quarantined in your setup. Okay, Gayatri. So Gayatri, because of the great efforts, what Delhi police or Delhi government has done, that even the suspicion is there, or the people, those who are living together and one person is positive, they are bringing to all the people over here. So, first time when we admitted the patient, we were getting reports almost after 4 or 5 days. In my meeting, when I raised this, that we are just investing our resources unnecessary. If we will have a rapid testing kit, then I think we will be able to have a rapid turnaround. So then AIMS has started, and yesterday, whosoever has come from this this mountain community, I think we have tested almost everybody, and unfortunately, I was so shocked yesterday night when I came to know the results that almost everybody is positive. So I was so shocked, and I was trembling because my residents have worked so much with these people, and the person who has died is also, it was also positive. One has intubated, one has put her on ventilator, and after explaining them, we are keeping them in a resort kind of a place where one room and bathroom is there, but they come to and talk to each other. So I don't think that they have understood anything. And our healthcare workers cannot go to 300 people and explain them again and again, otherwise they will get exposed again and again. We have created some kind of a WhatsApp facility that everybody is having a smartphone. Our doctors and residents, they go twice or thrice for rounds because they are otherwise well settled. They are just having mild flu-like symptoms. So in between, if they have any problem, we have created 2 or 3 mobiles. They can call on those mobile and they go and see those patients. This is the way. But many of our efforts, they are successful, but still if people will not understand, we will fail.
Thank you, ma'am. Any other questions? I think we have 2 more minutes before we go to our next thing in the agenda.
I think Dr. Pranab Kumar has raised his hand to ask his question. You can go ahead, sir. You
So
have to.
Gayatri has also asked me that what symptoms have you seen in very sick patients? So Gayatri, the very sick patients are those ultimately they either they are knowing that they have diabetes, but answer we get that diabetes है, but हमें नहीं मालूम कि क्या दवाई ले रहे हैं और control है कि नहीं है. So when we see the sugar, it is 500, 600. So the most sick patients are coming. We have not seen a lot of sick patients right now, but most of the patients are coming, like as I told you, with the mild flu-like symptoms. But if a patient is coming, they are almost they are just collapsing, they are dehydrated, and they are having little breathlessness. That is all.
Thank you, ma'am. Dr. Pranab, do you have a question? You can go ahead, please.
And and one more thing which I want to share, just this thing that nobody was prepared for it. So even if we will keep on teaching 100 times to our healthcare workers that this is the way you have to protect yourself, suddenly a patient collapsed and the security guard came and just he holded the patient and took him on his shoulder and put him on the bed. So this is 100 times we keep on teaching them, but and now this security guard is in quarantine, so it will become a multiplication that we have to just, because taking care of this, so many people are infected, then we have to take care of others. How many deaths, Dr. Lulu? Only one death till now. Please discuss the rational use of mask and N95. So mask and N95, we keep on working, discussing this. This is a big topic of discussion in everyday's meeting. Since last 1 month, we are having a meeting from 8:30 in the morning, which we always finish at 11:30 or 11 o'clock. And using a mask is a big matter of discussion. Yesterday, there was a discussion whether we should use mask or whether we should not use mask. I think then I said that whosoever is comfortable with mask, prophylactically, please use it, and whosoever is not comfortable, don't use it. Regarding N95 mask, we are very strict that we don't want to use too much N95 mask, but people, those who are intubating anyway other people, we have started using N95 mask. So I gave a few number of our nurse in charge give few number of N95 masks to duty doctors, so that if he is intubating a person who is not COVID or we don't know about any respiratory illness, serious respiratory illness, if any patient is coming, we are using N95 mask and we are using full protection. What will happen to patient when they stay in the quarantine and when they get discharged? So if a positive person is there, we take 2 samples, consecutive samples. If they are negative, we discharge them with a strict this thing that you have to stay for 14 another day in your home. Okay, so we have a separate session of PPE, so we don't have to work on this. Okay. Pankaj is asking, is it happening that some mild cases are going undiagnosed and getting well on its own? If so, how dangerous are they in spreading? Oh, it's very dangerous, Pankaj. If mild cases, because we are still considering it is like a mild flu. If they are there, they will spread. I think chain of reaction will be there. They will spread to the family members definitely. And it is true that if a family member is positive, we are keeping at least 5 family members in a row. So all 5 members are different in the different rooms. So this is happening that all other family members also get it.
Thank you, ma'am. I also see Dr. Anil Paleri's comment that during the initial phase, most of the deaths would happen in major hospitals with ICU facilities. But if there is community spread and the numbers go up, it will be everywhere. And I think it's true. And Dr. Lulu asked, how many deaths in your center?
I told you only one death.
Okay, ma'am. Yeah, thank you. I think we'll go to the next item in the agenda, and this will be taken up by Dr. Gayatri. And the theme of the topic is all patients must be cared for. And Dr. Gayatri, over to you.
Yes, thank you, Sushma. I think that was a very interesting and a very informative and I think a little scary overlay about what we are going to face ahead. And so, how prepared are we going to be, and what is that we as a palliative care, the scope of our need in this whole scenario is what I'm hoping to discuss in the next session. Next slide, Vinila. And palliating a pandemic, that's a topic, yeah. So I'm going to discuss this based on two papers. One paper which came to the 2010 and very relevant, I think, I thought, seeing that paper, and something which came just recently, one day before. So I just compare these two papers and see, based on that, our preparedness in facing this crisis. So this is a paper which came in the New Change Management, February 2010, and authors James Donner et al. Next slide. And they went on to say, Nila, just can you go on? Yeah, that's it. They said, they talked about pandemic. They talked about a pandemic like influenza. They said, if there's a huge population getting affected, the key principle of healthcare planning is that all patients will be cared for. So every patient will require care. But when we have a very scarce healthcare resources, many healthcare systems will implement a triage system that will potentially deny critical care treatment to some seriously ill patients. So this is what is going to happen. And I think, I'm sure in India, suppose unfortunately, I hope it doesn't happen, we may reach a situation like this. Next slide. And they went on to say, next slide, in that triage, most triages, they talk about palliative care for such patients. When they are denied or not given the life-sustaining measures, they may require palliative care. Next slide. And however, there's no plan for that surge which may appear in managing such patients. Next slide. Next slide. Now, what will happen to those frontline workers? Because they are the people, like today I'm sitting here very comfortably in my home, but they are the, like Sushma mentioned, her residents, her people who are working there day and night, nurses. But they are going to face all this time. And what is going to happen? This is what, based on their paper I'm discussing, they will be working in a very unfamiliar condition because they are not used to this kind of dying, witnessing so much of symptoms dying and so many patients and excess workload. Next slide. And they'll be seeing a lot of patients dying with uncontrolled symptoms. And they will be unprepared to deal with those symptoms, and they'll be unsupported because hardly any supervision, because there may not be many senior doctors around to help them most of the time in most setups. So this is what is going to happen with health frontline workers, and they'll be undergoing a lot of stress and a lot of post-traumatic stress disorder. All those mental health issues are going to come up. Next slide. What is going to happen to the patients in the family? Next slide. Now, when we say they will be denied the life-sustaining measures because of scarcity of resources, they'll feel that they suffer double insult. One, being denied a potentially life-saving therapy in a trial system, and then forced to die suffering. They may feel somewhere they were let down. Next slide. And they'll feel that they're abandoned by healthcare system entirely. So this is going to be terrible for the patient and the family. I keep hearing that elderly patient, they will not be put on ventilator. A healthy elderly will be so scared to even hear that when we talk in such terms. So this is what is going to happen. Next slide. Next slide. So what they did, they project that 2010, they projected a picture, a scenario, what may happen in Ontario health system, because based on some guidelines, like which model given by CDC, they said, suppose a influenza pandemic happens in Ontario. This is a very but it's not a real life situation, but they created this. They expect that at that point of time, there would be around 60,000 patients who require hospitalization, out of which 9,000 will require intensive care, 4,500 will require mechanical ventilation. Next slide. And they also said that if that's and what was at that point of time, the ventilators, like Sushma projected our situation, this is about a very more well-developed country where they said they have around 1,000 ventilator support ICU beds and 90% are occupied at any point of time. But by week 4 of the outbreak, mechanical ventilation capacity will be 200 because non-influenza patients will always be there in addition to influenza patients. And by week 5, almost 200 patients will be dying every day, and so many people will require hospitalization. So this is a picture they created based on the estimate. Next slide. And they seriously realized that seriously ill patients denying life support therapy may actually exceed the number who receive it. I think this is going to be very similar in our country, that people who may get ICU care may far exceed, who are not going to get ICU care may far exceed people who may get ICU care. And ideally, they would all require palliative care. Next slide. But we know that in that study itself, they mentioned that palliative care resources much less than the critical care resources. But Sushma mentioned about critical care resources being so less, we don't have even that much for palliative care. And what is going to happen? This is what they projected in that estimate. Next slide. So what they said at that point of time, that we need to have a plan, and they developed a plan, they suggested a plan based on a critical care model if that kind of surge happens. Next slide. Which they talk about a plan which will consist of staff, space, and system. System was added from palliative care point of view. Next slide. They made this summary of a palliative care pandemic plan. I'll go into each of this quickly. If you look at the stuff part of it, they say, if you are thinking about a palliative care pandemic plan, we must have enough medications available, like opioids, haloperidol, for secretions. We use glycopyrrolate, they said scopolamide, enough of other equipments, and we also need to talk about PPE, personal protection equipment. So we need to stockpile these medications if you are planning for a palliative care pandemic plan. How about staffing? We don't have enough staffing, they said. So they said, we need to focus on education session for frontline staff for symptom management and end-of-life care. There should be standardized sheets and protocols so that they can be helped to manage those people by themselves, and take off other allied healthcare workers to support them in this need, because a lot of these other things can be managed by a multidisciplinary team. In terms of staffing, they really recommended focusing on education of frontline workers and developing standard guidelines and protocols. Space. They spoke about very soon we may require a lot of space dedicated to move people who will not be on ventilatory support. So we'll need a separate facility for housing these kind of patients who are dying but symptomatic and they are not on ventilatory support, to maximum utilization of space. If you come to the system part of it, they are talking about, again, triage, who will be referred actually to palliative care, who will be managed by the frontline workers, and how many they may require intra-facility, inter-facility transfer of these patients. And they also talk about ensuring all patients admitted to healthcare facilities having a clear and updated advanced care planning, which may not be very relevant here, but they speak about that. So this is the summary of the pandemic plan we talk about when you're planning a palliative care pandemic plan. Staff, space, and system. Next slide. They also said that who are the patients who may require a direct palliative care referral because of the very limited resources. They said patients with complex symptom control and whose symptoms are not completely controlled by standardized protocols. Those patients may require some more specialist palliative care intervention. Patients who are already seen by palliative care specialists, we still have a huge population living with life-sustaining conditions. They are there. They are not going to go away, and they need our support anyway. So that will continue. And those patients who have been denied life-sustaining treatment because of the triage system, so they may require more palliative care intervention. Next slide. Next slide. So they said, at that point of time, they said, we are fortunate that this is not happening. This kind of demand for hospitalization, increased critical care resources, and triaging is not really happening. We are very fortunate. But they said in 2010, there is no guarantee that will not need so in future, either for present H1N1 or other viral respiratory illnesses. This is what they said in that article. But they spoke about having this pandemic palliative care plan. Next slide. Fast forward today. This is an article which came in BMJ, British Medical Journal, March 31, 2020. They spoke of, this is a blog by Italian group. they spoke about their own experience of what is happening to them. They said how, like Sushma, very similar curve if you see. First case, they said they found in a small village where they found first patient 21 February. After that was a lot of panic, anxiety, and soon it just went out of control. It was a local hospital which perceived the gravity, and they rapidly decided to get into some kind of triaging in intervention. What they did, next slide, they converted almost all wards into COVID emergency departments. So almost all wards were converted into this surge of dealing with people. Next slide. And they also had this difficult and controversial decision of creation of a dedicated ward as end of life department. Now this is everywhere. This is being debated. It's very controversial and very difficult. And we're already seeing that in India. But they did that because they saw the surge. Next slide. Next slide. And how the palliative care team was supporting them. The team in that group in Italy, they assisted with organization of newly created structure. They organized that end of life care department. They quickly developed some guidelines for frontline workers, and they also made sure how to provide appropriate therapeutic interventions such as use of morphine and benzodiazepines for symptom relief and alleviating suffering. So they helped, the palliative care team helped the main frontline workers with these kind of aspects of care. Next slide.
Dr. Gayatri, you have 1 more minute.
Yeah, I'm done. Next slide. And the referrals were interestingly done by the emergency department physicians, and they looked at some criteria like multiple comorbidity, like Sushma mentioned, that which patient would not benefit from aggressive measures. And next slide. And interestingly, the people who are managing end-of-life care department were not palliative care. They were primarily surgeons, actually, because they were the people who were relatively free and they were managing the department with proper guidelines. Next slide. Outcome was it was not a typical palliative care program because there was no patient-family interface, no typical palliative timing for planning and sharing of information. Nothing was happening, but they were all dying. Next slide. Yeah, and there was a compassionate management of terminally ill, and there was a fair distribution of resources. Next slide. Sushma showed this curve where we are today with this, and we don't know how the next 2 weeks is going to be. Next slide. In India, but we have to take into some consideration when preparing this. How do we maintain that the public is not harmed? All patients are cared for. Duty to provide care. There's a controversy around how we have this obligation towards our own safety and our family. In that context, how are we going to take care of these patients? But then the argument is that we came into this profession knowing that we will always be exposed to these kind of serious risk with communicable diseases. Reciprocity, which means that we have to take care of patients who are dying, irrespective of what is happening, and how best we can help them, giving more attention to people who are going to be denied life-sustaining approach. And equity, still we have those other group of people with life-limiting conditions who require care, so we cannot abandon them. So right now, I think all palliative care group in India are still dealing with other life-limiting conditions. We cannot abandon them. How do we maintain that with this together is something we need to plan. Next slide. So to conclude, we all agree that all patients must be cared for. And if we need to see what's going to happen in India, and if palliative care needs to get involved, we need to have this plan. Next slide. How do we plan? How do we maintain the staff, space, and system? So this is the kind of thing which we, based on the 2 articles which I thought I would share. Thank you.
Thank you, Dr. Gayatri. I think it's very interesting discussion to talk about palliative care and infectious diseases. Just before we go into discussion and further answering questions, I just would like to invite Dr. Megan to give global updates of what is happening and if there is any palliative care happening elsewhere.
Thank you very much. My comments will be very brief. Every week, we're going to try and give a very brief update on something that's happening in another country that we can maybe draw lessons into our own situations. So one thing I wanted to share very briefly from those who registered through the Google Sheet that we circulated, These were the most important concerns you had related to COVID. How to adapt palliative care programs to COVID situation. And Gayatri has shared the article from 2010, and we're going to have further discussions in further weeks that further develop that idea. And the rest of your concerns that were highlighted, the most interesting topics we will cover in our future sessions. Next slide. Gayatri spoke about this article from the BMJ, this blog post, How to Manage in the Ultra Emergencies. And I think this really speaks to some key points that Gayatri has already highlighted, so I'm not going to go into them again. But if we were to summarize what's our role as palliative care providers in this situation, it's part of our role as organizing to ensure that all of the patients we have a responsibility to receive appropriate care. And that's care that treats symptoms and reduces suffering. And that's care that has communication that's clear and compassionate, and at the same time addresses the resource distribution issues that we've been talking about, that resources are distributed appropriately, proportionately, and ethically, which means based on needs and based on what's available. Next slide. I will share one example of a very simple tool from Italy. I think we're going to pull in one or two of these each week to give you some ideas of information that's out there in the palliative care world that's being shared. This was a great communication tool that we found that the Italian palliative care group prepared, not for themselves to use necessarily, but to support all the other physicians, nurses, and healthcare workers who are suddenly thrown into a situation where they have to do difficult communication over the phone with families very much on a regular basis, not something that most of our surgeons do every day. Imagine being a surgeon on this ward in Italy where you're just doing end-of-life care. You need some guidance how to have these conversations. So this tool was created. It's simple. It's one page for the conscious patient. And on the next slide, we have one page in case of unconscious patient. Next slide, please, Vanilla. So we'll share this tool. It's in a Word version. It could be adapted. We can think about how we could adapt it to our own contexts. I'm going to stop there for today in the interest of time and hand it back to our facilitator.
Thank you, Dr. Megan. I think it's very interesting that palliative care physicians are trying to help the frontline workers in communication and symptom management. And I think in India also we are trying to develop local guidelines so that if the need arises, it can be accessed easily. Now I would like to invite the participants for any questions they have, any thoughts you have, anything, because the whole point of creating this platform is not because we are the experts, but we want to provide a platform for this discussion. So please go ahead.
Hello. Dr. Stanley here. Can you hear me?
Yes, sir, we can hear you. Please go ahead.
Thank you. That was very helpful. I fully agree with all the measures you're taking, but I think we have to quickly develop what we call develop local guidelines. So based on all these inputs, I would say that we need to have fairly quickly a meeting on Zoom by the IAPC Central Council and others who are interested, arranged by Dr. Sushma and Savita, and to develop local guidelines. Yes, we will have to continue, as you said, with all the areas where we have to take care of all patients. So that would mean where COVID patients are admitted, if the palliative care is needed, there we must help. We must also help even in our other hospitals, all the others who require palliative care. And the third group is the group which I hope will not be the issue, because if it goes out of hand and the numbers become very large, people will be dying at home. And so there we have to see how we can strengthen the family, which will be the main resource, and also how we can reduce suffering and help people to die peacefully at home. And this is how we will have to approach them, by teaching them the subcutaneous method of helping them to have even palliative sedation if needed, because that will be the only way to keep them comfortable and help them to die a good death. Thank you.
Thank you,
Can
Dr.
I
Stanley.
can I
Go ahead, ma'am.
see, because of any epidemic or pandemic, this what happens that we all concentrate on that particular disease, and then other diseases which people are dying that get ignored. So this we have to take it very, very seriously, because our patients, those who were dying anyway because of cancer or because of any chronic debilitating condition, so for that we have to have a very good plan in place. So we at AIMS started doing it almost 2 months back. One thing which we have done, that our follow-up now is they are not coming every 15 days, they are coming for 1 month, and if we are sure that this patient will survive for 2 months, we are giving medication for 2 months. Then we have started telemedicine consultation. We don't want to expose ourselves and themselves, so we have started telemedicine. Plus, in emergency, any patient who is coming with breathlessness, we are considering that if patient may be infected, we are taking full precautions. So this is also very important for healthcare workers and palliative care physicians, that palliative care, when we are talking only about the COVID, there are multiple patients those we were treating before, they also need treatment, and they should not be ignored, and otherwise they will suffer unnecessarily because of this prominent healthcare emergency which has come to us. Thank you.
Thank you, ma'am. I see in the chat that there are some guidelines prepared mostly by the Kochi group, and there is some talk about getting uniform national guidelines. We hope that comes out. And yes, I agree, the next 2 weeks will be really crucial for India to see how the trajectory is going to go. So any other questions, any other thoughts? I think we are all talking mostly about planning phase and how to take it forward in case the situation arises, which none of us hopes for. Any other thoughts, questions?
I mean, I think that you have a tremendous opportunity to lead, because you're already thinking about these things. It's wonderful. The group in Kochi is already developing guidelines, but just reflect on how this will change all of our practice. I think all of a sudden our whole palliative care world has changed. I saw today on Twitter, one of my colleagues sent a tweet. He said, "The things I would never have done for good communication before are all the things I have to do now. I have to talk on the phone. I'm rushed. I'm in a noisy OP, and I'm trying to provide good care." And that's a real challenge for all of us, because we came into palliative care, I think, many times because we wanted to give really good care. And it can be a big factor for us to burn out if we feel like this isn't the way we want to give care. But we're unfortunately in a new world.
I want to share my one very important experience, that it is not going to be easy to talk healthcare workers about palliative care in this group. When I talked to AIMS authority that we should start discussing palliative care in COVID patient, in AIMS everybody accept this concept of palliative care is so well. They have already they have already integrated palliative care in various diseases, and non-malignant as well as malignant. But the answer which I got is that, oh, this is an infectious disease, completely reversible. Why are we talking about palliative care in these patients, and why are we talking about the ministry will get so offended that they are purchasing 30,000 ventilators, and we are talking triaging of ventilator. So many things. It's not going to be easy to convince people, and I think it's a good effort that we have started doing everywhere. The palliative care physicians are doing something. They are making guidelines. They are trying to convince it. So because of COVID, this is first time this has happened, and after 100 years, some pandemic has happened. So for pandemic, palliative care integration is going to take a lot of effort for your for you, and it will be a challenge for every palliative care physician.
Yes, ma'am, I agree. A lot of times the question keeps coming from our co-workers in other specialties that why are you even talking about palliative care? And with that, I would just like to mention one question Dr. Bikash asked, and I think that would be a repetitive question, is when is the time to start palliative care in a pandemic crisis? So I don't know if it comes under the purview and the time limit of this topic, but any thoughts?
Right from the beginning, I think in my experience, which I am seeing the patients, that right from the beginning, once the patient is isolated from his family members and he is seeing every day, everybody sees in the WhatsApp the news, they see, then they start thinking that I'm going to die because of this disease, but death is only very less percentage of people are dying. So I think again the concept of palliative care should start from the beginning, good communication, and it's also very difficult to communicate patients because we cannot go again and again face-to-face communication is not possible very frequently. That what we do in other patients. For these group of patients, we have to find out a solution, talking to them. Once the doctor will go, then again we cannot go. So he is depressed or not depressed, what he is feeling, we don't know anything. So right from the beginning, palliative care should start.
Thank you, ma'am. Any other thoughts, anyone,
Hello.
when palliative care should start? Please go ahead.
Can I? Yes, I would just like to emphasize again that we need to urgently develop our national palliative care guidelines so that we can convince the government and everybody else, that this is an important aspect of care for all, COVID and non-COVID, and for everybody, because we have to be there for people who are suffering in whatever way. So we need to have special guidelines for this particular situation which has come up. And therefore, I would urge that we get together and develop these guidelines as soon as possible. Thank you.
Thank you, sir. I'm sure we'll come to that very soon. One more question I see is about hydroxychloroquine. So there is a lot of divided data on whether to use it or not to use it. Anyone would like to share your thoughts on it?
About hydroxychloroquine, it was a big matter of debate, like mask in every meeting. So whatever data says that if a person there is no contraindication, the person is not having any heart element or something like any disease or LFTs are not deranged, I think they can take hydroxychloroquine for this thing, but there are no convincing data that whether it helps or not helps. So even a patient, those who are coming to our hospital, they are asking hydroxychloroquine. Patient is asking. So then we are just thoroughly examining and then we are giving if they are very healthy. So it's again, we cannot say that whether it's going to really effective, but people are using it, and most of the 99% people, they are taking precautionary measure as a precautionary measure hydroxychloroquine. Even I have taken hydroxychloroquine. It's so horrible. It causes a lot of gastritis, so we should be very, very careful.
Yes, the information is out there for the public, and I know a person who hoarded 200 tablets just in case. So data has to be, it has to be weighed in. True. So there is one thing Dr. Vidya says, Dr. Raju in Vizag, what he did since last 2 months was sensitized old age homes and finding ways for social distancing and ensuring food supply and medicines for 2 months. And it worked really well. And as we know, geriatric population gets affected. I think it's a very good measure. Any other thoughts? And there's one question from Dr. Renuka, how to triage the caretakers and even a non-COVID patient end of life, how do we screen caretakers and whether we allow them inside or not? And any thoughts, any centers, palliative care centers, what are you doing in this critical time?
Again, can I share with the caretaker's experience?
Yes, ma'am, please go ahead.
Caretaker experience, again, we are not that comfortable with the way we take care of other caretakers, because again, we are worried because they are isolated, they are in quarantine. The caretakers are also in the quarantine period. They are isolating themselves. and we are worried that we should not get infected with it. So again, it is not going to be that easy. Face-to-face discussion hardly happens. So we are talking on WhatsApp and we are talking on phone, and if at all we want to talk to the caretakers, we will be on full PPE and will cover mask. And when you are in mask, I don't think that when there is no eye-to-eye good contact, I don't think that we can talk to any person. So it is going to be a challenging talking to caretakers also.
I agree. Dr. Gayatri, would you like to share your experience at Hyderabad Hospice?
But that's a typical example of non-COVID patients and families. I don't think that will be relevant here. What exactly is your question? Sorry, I didn't get it.
So in the chat, they asked both about COVID patient and even a non-COVID patient. So for now, I think we can answer non-COVID.
Yeah, I think like many other centers, we are totally every day, like the full day almost, our team is constantly on video calls and spending this lot of time with the patients and the family because they have a lot of issues, anxieties around their own what they're undergoing experience, and in addition to this anxiety about because their vulnerability to COVID infection, so they need a lot of reassurance and a lot of talking. So our doctors and nurses and counselors are constantly on the job through video conferencing and teleconferencing. I think many centers are doing similar things all over India.
Thank you, ma'am. I think we'll take one last question and we'll wind up the session because we know we are crossing the time. One thing they have, sorry, there are a lot more chat coming up. So Catherine says, I'm working in Jordan in the Middle East. We are following one family member to remain at the bedside. Yeah, and with no other family members allowed to visit. Knowing how hard it is going to be, we still have to take these precautions for our patients. And Rachel says the same thing about advocating for inclusion of palliative care. And she suggests the role of how we communicate the role of palliative care in a pandemic. I think it's going to be very, very challenging, and all of us have different arguments. And yes, it will be good to advocate for palliative care even in infectious diseases. And Dr. Lulu asked, anybody has started children contacts on HCQs? Anyone with experience? Because I haven't seen it done. Anyone who started children contacts of COVID patients on HCQs?
No, we haven't been recommended to start. We're following the guidance of our public health of Canada, and they have not said that we should start because the evidence is so weak, basically.
Yeah, Megan, I agree. We have not given, there are 3 children, they are the 3 family members, and they are 1 3 years old, 4 years old, and 8 years old. So we have allowed these children to stay with the mother first thing, because they cannot stay alone, and second thing, we have not given them HCQs in these children.
Thank you. I think we are at the end of the session. So I have one request from all of you. Dr. Gayatri shared the link in the chat and we are going to share it again. So it's a Google spreadsheet. If you can share the questions, because as you know, we are all trying to find the answers, and sometimes it's very difficult when they come up in the moment. So if you can share your questions, that would be really good. And Dr. Mahesh, you asked about home care for non-COVID. We are going to cover it, but it's going to come up in the next few sessions. And if you have any feedback on how you want the sessions to be, because we have planned them to be very dynamic, to evolve according to the need, we would be happy to change them as such. And we would try to answer all your questions as much as possible. Thank you very much, everyone, and thank you for coming. And we will all see you in 1 week time, if not sooner.
Thank you, Gayatri, everyone who has organized Megan.
Thank you.
And I think it was very good and very informative. It's a good initiative, Gayatri.
Thank you. Thank you very much.
Thank you, Dr. Sushma and Dr. Gayatri, for presenting. Thank you.